Good morning, and thank you all for coming out, braving the early morning time for this symposium. We're delighted to present this CME program conducted by PeerView Live called An Immune Reset for Systemic Lupus Erythematosus, looking at the horizon for CAR T-cell therapy in lupus. My name is Philip Mease from Providence Swedish Medical Center in Seattle, and
I'm Drs Askanase. I'm a rheumatologist, and I'm the director of the Lupus Center at Columbia University in New York City.
So we want to thank PeerView and also BMS for providing the educational grant for this symposium. There is a pre-event survey which we'd like you to fill out, and there's going to be a series of polling questions, and in a slide or two, you're going to see the QR code for being able to fill those out on your personal device. And if you have questions, please submit them through the Q&A feature in that. Even for those of you in the room, but there are also a number of virtual listeners who will be putting in questions. Here is the QR code for you to scan. And again. So what we'll be doing today is walking through the deficits in the current treatment landscape for lupus and why it is that there's an important opening for CAR T-cell therapy coming to us, and go through the details of how that has done for you, and summarizing some of the data that we have to date. So here is our first polling question. Reflecting on your practice and select the option you think represents a challenge or ongoing question related to current therapy for lupus. Avoiding toxicity associated with steroids, need for new options for treatment refractory disease, understanding the rationale for CAR T in lupus, the potential role of CAR T within the spectrum of lupus therapies, knowing who might be a candidate for CAR T in your practice, building appropriate infrastructure and team, especially with the HEMOC group in your center for having a CAR T program, and you'll hear more about that from both of us, or all of the above. Should have started with that last one. Okay, the great majority of you said all of the above. Very good. Okay. So this is a slide that doesn't need to be shown at this meeting, but it nonetheless ground sets the point that for many of us, we're seeing patients referred to us who have been around the block with multiple clinicians based on a variety of symptoms that they've had and not coming to the appropriate diagnosis. And so oftentimes there's a significant delay in making the diagnosis of lupus, which unfortunately leads to the problem of cumulative organ damage, especially in the kidney, but also potentially other organs as well. In addition to organ-specific pathology, patients are troubled by significant pain, brain fog, depression, fatigue, and then amongst young females, especially Black and Hispanic, it's one of the leading causes of death, along with morbidity. This is a graph that speaks to the cumulative damage of ongoing steroid therapy, especially in problems such as osteoporosis, avascular necrosis, ocular, neuropsychiatric problems, and so forth. And here is a survey of treatments that have been done both in the US and in Europe over a several-year period. And the basic take-home is that there's not that much change going on, so people are still using predominantly hydroxychloroquine and steroids, and to a lesser extent, oral DMARDs such as methotrexate and azathioprine. We're seeing a bit more in the way of more advanced immunomodulatory therapy being done, but it's still at a very low level relative to the need of patients. So this is the basis for needing newer cell therapy approaches, and especially CAR T, which everyone here is very, very aware of. One of the issues that coming into CAR T has been, well, why is it that we need CAR T if we have monoclonal antibodies that can deplete B cells? And the take-home message is that agents like rituximab just don't do enough to adequately deplete the B cell population, and thus there is not a resetting of the immune system with naive and non-pathogenic B lymphocytes. So let's get into some of the details about CAR T therapy. As you know, there are three major methods: autologous, which is where the patient's own cells are used; allogeneic, where we have off the shelf, so to speak, cells from a healthy donor; or in vivo, where there is engineering of cells that goes on inside the body based on stimuli that lead to that. So we're already seeing an evolution from the early days in which CAR T cell therapy was being used first in cancer treatment to the current time, and that has also included an evolution of the CAR on the cell surface that is being engineered. So here's the process where T cells are collected from the patient that has been identified to be a refractory lupus patient that would benefit from CAR T cell therapy. The cells are shipped to a manufacturing facility, and then typically using a lentivirus or other type of vector, there is this engineering process going on to then establish the CAR, usually CD19, but it could be CD19 and BCMA, for example, that is expressed on the lymphocyte surface. The cells are then expanded. The cells are shipped back, and after a lymphodepleting regimen, the patients are infused with their own cells in the case of autologous therapy. And if it's an allogeneic approach, then the manufacturing process is eliminated. So what we're looking for is taking a patient who has many different pathogenic B cells, memory cells, that are then exposed to these T cells that deplete them. And there's a period of anywhere from 90 to 150 days where the patient is significantly B cell depleted. But then the cells coming back from the marrow are, as you will see, for the most part, naive B cells that are non-pathogenic. One of the things that we're trying to do is target the cells in the B cell lineage that are most likely to be contributing to pathogenesis, and that is extends from the pre-B cells all the way through to plasmablast and potentially plasma cells. And when it's a CD19 targeted agent, then it's just those cells that have CD19 on their surface. If it's also BCMA, then that will include more plasma cells. There are toxicities potentially, and we'll be talking about those. We've learned a lot about cytokine release syndrome, CRS, and ICANS, the neurotoxicity syndrome, from patients with lymphoma and other cancers that have been treated with CAR T-cell therapy. Fortunately, what we're discovering is that these reactions are much less severe or frequent in lupus patients, and this is presumably largely due to the reduced number of cells that are being affected in autoimmune patients as compared to lymphoma patients. There are a number of advantages of this approach, including the fact that at least in some of the patients who've had very durable remissions that we are tracking, who were treated originally in places like Erlangen, Germany, or in China, there may only need to be a one and done infusion. However, we're also anticipating that there are going to be patients for whom this isn't a completely durable remission and may need retreatment. We're now seeing that not only is there significant B cell depletion and then reconstitution with non-pathogenic B cells, but also changes in the immunophenotype of T cells and NK cells, so a true resetting of the immune system in those patients. And the hope is that they'll then be able to maintain long-term remission without needing their standard therapy for lupus. There are a number of drawbacks, and one of them is that in the conditioning regimen, before the cells are infused, we've been giving patients Cytoxan, cyclophosphamide, and fludarabine to reduce the likelihood of having rejection of the cells that are infused. We don't fully know what the potential safety issues of those, other than we know that they can be lymphodepleting, cause neutropenia, and so forth. But also, we don't know exactly what the conditioning regimen may do for the fertility in young women. All of this is a very heavy, resource-driven process, quite expensive. What we're hoping for is that down the road, when you consider the cost of a one-and-done treatment versus ongoing treatment with immunomodulation and the risk of that, as well as the cumulative impact of changes, for example, in the kidneys, that they balance each other out, but it's a very expensive process. We have been, in most of these studies and treatment in general, we've been partnering with the hematology oncology teams at our respective institutions. The rheumatology team is responsible for identifying patients that are in a refractory state and educating patients. I can think of multiple hours that I have spent on Zoom calls with patients and their families. Where I live in Seattle, we have many of our patients are coming in from a distance. They're flying in from states like Alaska, California, Nevada, as well as regional patients. And so there's a lot of interaction that goes on at the front end of this process to educate patients, to really have them understand what they're getting into, because it's a arduous process with hospitalization and whatnot. And then the patients come in for screening and identification that they truly are appropriate for this type of treatment. And then there's washing out of their current therapy that occurs using steroids typically to bridge during the period of washout from mycophenolate or belimumab, for example. And then they undergo a leukapheresis process in the autologous case, and then LD chemo and CAR T infusion. During this period, the hematology team is heavily involved, both for just because they're the ones that really know, the nurses on the units where these patients are being hospitalized, and then monitoring for toxicities and treating appropriately if there are any. In the short run after the procedure is done, both units are working together, and then in the long run, it's the rheumatologist that will be following these patients out, as the FDA has mandated for us to follow patients for 15 years in terms of any potential toxicities, as well as monitoring ongoing efficacy. So that's summarized again here. I think we've already gone over these points. On the left are identified some of the currently approved therapies for cancer treatment that are CAR T cell therapies. And then on the right are just a handful of the current programs. So what we have found is that many of the companies that have developed CAR T therapy for treating cancer are now including typically in basket trials, trials for lupus, scleroderma, myositis, rheumatoid arthritis, and they're all in either phase 1 or early stages of phase 2. Most of the targets are CD19. Some are CD19 and BCMA, some CD19 and CD20, and some BCMA alone. So this is a summary on a single slide, the data from the Erlangen group that was published in January of 2024, Mueller. 8 patients with lupus and others that had myositis and scleroderma. And you can see that at this point in time, all of these 8 patients who ranged in age between mid-20s to mid-30s, all had very refractory disease and had been on multiple treatments, are in DORIS remission. The longest out is around 5 years in DORIS remission state without treatment. All of the patients are in LLDAS and have 0 SLEDAI scores. As you'll see when we get to other therapy descriptions, this type of really good outcome is not necessarily going to be the case for every patient, but fortunately so far the majority have been. You see also the corresponding decrease in DNA antibody, as well as normalization of C3. And for the most part, a significant decrease of urinary protein excretion. There were a total of 5 of the 8 cases that had CRS, cytokine release syndrome of grade 1. This was typically just fever. In our center, if a patient has a fever on one day, it's treated with acetaminophen. If there is a second day of fever, what the HEMOC team has been prone to do is to give them a squirt of tocilizumab to treat that, and that's it, basically. In this particular group, there were no ICANS or neurotoxicity cases, and there was 1 case of pneumonia requiring hospitalization. Here is a schema of the BMS study, their phase 1 autologous CD19, and you see the regimen that we've just walked through, screening, leukapheresis, lymphodepletion with cyclophosphamide and fludarabine, and then treatment with cells, and then careful monitoring in the hospital for approximately 2 weeks. They're in the process of going through dosing level changes with 10 times a million cells going on to 25 times a million cells. And in this basket trial, there are also patients being admitted with scleroderma and myositis. We've had, in our center, 2 of the scleroderma patients, for example. The key outcome from these studies is, of course, evaluating safety, And the secondary endpoints are looking at efficacy data. So here is some of that efficacy data shown here. SLEDAI improvement in the majority of cases, quite significant, and improvement in the global scores and functional scores. Here we're seeing biomarkers of improvement, including improvement of DNA antibody normalization of C3 and C4. And then importantly, the change from pathogenic memory B cells that have been depleted significantly, and then the cells that are coming back are naive cells. One of the points that has come out of the Erlangen group that's of interest is that the cells that, the plasmablasts that are affected, which appear to be the source of for DNA antibody and other autoantibodies, but there's been some sparing of plasma cells when you use CD19 therapy approach alone. And there was preservation of viral memory for vaccinations. So measles, mumps, SARS-CoV-2, and so forth were not impacted by this therapy. Here is a summary of the safety features so far with this program. We're seeing some hematologic changes, neutropenia, anemia. There have been a total of 3 infections, no cases of prolonged cytopenias. And then as we look on the right-hand side for CRS and ICANS, these have been mainly grade 1, as I just mentioned, fever, treated with either acetaminophen and or tocilizumab. 2 cases of grade 2 CRS, and then there was 1 case of grade 3 ICANS of the neurotoxicity syndrome, the patient that had a kind of obtunded state, but then recovered quickly from this, and that patient was treated with dexamethasone. These events occur relatively early, within the first 7 to 10 days of therapy, and are short-lived, 2 to 3 days. There is in the Erlangen group, there's also a parallel program called the Castle study, which is noted here. And these are enrolling, the Castle study is designed in a very similar manner and looking for the same issues around safety and efficacy. And here we see efficacy and safety data from the first patients in the Castle program, in which there is relatively low incidence of CRS and a single case of ICANS. As mentioned, there may be some value in targeting BCMA as well as CD19. There is a product from China that is being developed, and this is some of the early experience with this approach, which also is showing efficacy not unlike what we have seen with CD19 alone. One of the issues, though, that with this type of therapy that we'll have to be considering is revaccination of patients, since this targets a bit more the plasma cell population, and so thus may reduce viral memory. We've already gone through this, but just to summarize what constitutes CRS: fever, hypotension, potentially tachycardia, hypoxia. And then for the ICANS issue, headaches, confusion, delirium, aphasia, possibly seizures, and cerebral edema. And these are some points about management of these, including use of acetaminophen, tocilizumab, dexamethasone in the case of ICANS and ICU management. This is a summary of some of the types of long-term adverse effects that we'll be monitoring for, including late events, hematologic, neurologic infections. There has been a report of a total of 20 T-cell malignancies that have occurred in the cancer population that's been treated with CAR T-cell therapy, and 3 of these had a cell signature for the CAR transgene, so may have been related specifically to the CAR T therapy. And so that is something that we now counsel patients about, and that's to be compared with or balanced with whatever their toxicities that may occur, or even malignancy from some of their ongoing therapies like cyclophosphamide or mycophenolate. So if you could address this follow-up poll with your personal device. Can you pinpoint the potential benefit of CAR T therapy in the lupus setting? 1, I'm still unclear on the potential benefits of CAR T. 2, annual infusions to deepen responses to disease-modifying maintenance. 3, one-time infusion to deepen responses to disease-modifying maintenance. 4, one-time infusion to allow for steroid retreatment. And 5, one-time infusion and potential sustained drug-free remission. Okay, it looks like this is a great aspiration for what we're hoping for here. Next one, reassess your knowledge. Which statement best summarizes the clinical experience so far with CAR T-cell therapy in lupus? I'm still not clear on the therapeutic potential. CAR T appears effective but induces high-grade CRS. CAR T has limited efficacy in treatment refractory lupus, and CAR T is effective in treatment refractory lupus, mainly with lower grade CRS reported. Okay. A few of you are still unclear, but with enough of this, you'll gradually get it. All right. Anka.
So wonderful to spend some time with you and think about where CAR T might fit in the treatment of lupus, and share the enthusiasm for the possibilities of the drug-free remission. So let's see if we can identify who are the right candidates for now for a cell therapy trial, and hopefully later on for cell therapy in our practices. We're going to talk about a patient, a 28-year-old woman, Virginia. Of course, Virginia is not a real patient, is not the real name. It is a real patient, but Virginia is not the real name. She's had lupus for about 10 years and has had ongoing poor response to immunosuppressant therapies. Mycophenolate mofetil, rituximab, and high-dose steroids failed to control the disease. So is Virginia a good candidate, or should we have more information? What else should we assess before making that decision? Of course, you know the answer. We need to assess more, and we need to understand better if, based on the current state, Virginia is a good candidate for cell therapy. So it's important to evaluate the past, but also the present. So the way the cell therapy trials have been designed, It's thinking about making sure that there is enough severity of the disease, enough activity of the disease, and administering CAR Ts to these patients is safe. This is very early, so safety is critical. So far, we have required that patients have failed 2 prior therapies. And for the majorities of the currently ongoing clinical trials, the requirement is for 1 traditional immunosuppressant. For Virginia, that was mycophenolate mofetil, and 1 biologic, that was rituximab. So that inclusion criterion is met. High disease activity, well, we have not learned about that, but we will in a moment. For patients that have prior kidney disease, the requirement, or are coming into the study for their ongoing lupus nephritis, the requirement is for a kidney biopsy. To make sure that CAR T is safe, there's a requirement for good kidney, heart, and lung function. The majority of the trials require eGFRs greater than 45 and ejection fractions greater than 45 as well. And thus far, while there were reports of a transverse myelitis lupus patient that did very well, the clinical trials that are ongoing are excluding patients with neuropsychiatric lupus. So how do we make sure that all this is happening? Well, we do the blood work, we check the kidney function, the lupus disease activity, we check the heart function with an echo, we check a CT scan and PFTs to make sure that the lungs are working well, and for patients with active LN, we do a kidney biopsy. Because of the concern that the ICANS may be interfering with the lupus symptoms or with prior events in the brain, a baseline brain MRI is needed. So all of this stuff needs to happen in the background. A lot of appointments with our hematology oncology colleagues, with neurology, nephrology, cardiology. So setting up the entry for a patient in a clinical trial is complex. So Virginia's clinical picture suggests that she might have active lupus nephritis. Her urinalysis shows an active sediment. The UPCR is 4.5. On the physical exam, she has a mild malar rash, and she has ongoing persistent bileg B arthritis. Her eGFR is 60, and we perform a kidney biopsy. The kidney biopsy shows class 4 lupus nephritis with an activity index of 7 and a chronicity of 2. So I submit to you that Virginia is an excellent candidate for CAR T because of her refractory disease. She has failed several regimens. Her severe disease, she has had kidney involvement, and she has persistent kidney involvement, and she has also active disease. So all of these make her a good candidate for a cell therapy trial. Are there other scenarios that are involving organ involvement and treatment refractory disease that would consider CAR T cell therapy? And the answer is yes. Patients with lung involvement, cardiac involvement, GI involvement, all have been considered, and thus far, some of these enrolled in clinical trials. So once we decided that Virginia is the right patient for the cell therapy trial that's going on at our center, our job is to start the conversation with Virginia. We review the benefits, the risk, the expectations, and emphasize the need for long-term follow-up care. We do hope that cell therapy is going to be a one-and-done treatment, but we need to make sure that we follow the patients and monitor them for any long-term possible complications. How do we counsel Virginia? Dr. Mease already told you that it takes hours, it takes a lot of trust building, it takes a lot of explaining and making sure that both sides fully understand what they're getting into. Are there specific strategies that centers use when they're talking and explaining the process. For the most part, I use my slide presentation much like the one that we're showing you today, and going through with the patients through the stages of CAR T treatments, through the expectations and the hope for CAR T, and just making sure that we understand and the patient is aware and has fully internalized the balance between the risks and the benefits. And there's also the conversation about the acute and late toxicities, about post-infusion care, about reproductive health. The conditioning regimen contains cyclophosphamide and fludarabine. For the autologous CARs, for some of the allogeneic, it's only cyclophosphamide, but discussing the risk of the chemotherapeutic agents in terms of fertility is important. And this is also part of the conversation that I have with patients, which is, what is the expected efficacy? We did a systematic review and meta-analysis of all the patients that have been presented in the literature, be it published data or series that were presented at the American College of Rheumatology meeting. We were able to find 14 studies that were evaluating the use of CAR T therapy in people with lupus that included 98 patients. All of these patients had failed 2 immunosuppressant therapies. 2 types of products had been used, anti-CD19 CARs for 12 studies. 2 studied included the BCMA CD19 bispecific. We were able to extract granular data on 63 SLEDAI scores that were available. For these patients, the mean SLEDAI score was 12.8, so high disease activity at the onset. And the mean decrease by 1 month was to 5.4, by 3 months, 3.6, and then by the 6-month mark, the SLEDAI was 2.3. So a lot of these patients are achieving low disease activity state or remission, while some still have persistent disease activity. Overall, high potential for extraordinary efficacy. And of course, always thinking about the safety. So in this group of patients, the CRS occurred in 56, so about 57% of the patients. The majority of these CRS events were grade 1, so just fever. There were 5 patients that had grade 2 events and 1 patient with grade 3 CRS. So all in all, yes, there is a risk of CRS, but the majority of these are grade 1 mild CRS. In the reported literature, ICANS occurred in 3 patients, 1 grade 1, 1 grade 3, and 1 grade 4. So very low incidence because we're almost at 100 patients. So about 3% of the patients have developed ICANS, much less than what has been reported in the hem-onc literature. Infections were observed in 21 patients, and of these, only 6 were severe. So 6 out of 21 is 29%. There were several cases of severe or prolonged cytopenias in 36 patients, 37% of the population with cytopenias. So hematologic toxicity is rare, and there are instances of severe cytopenias that need to be followed. So thinking about Virginia, our 28-year-old patient with long history of lupus, treatment refractory, severe disease, and active lupus nephritis that had been on mycophenolate mofetil, rituximab, and high-dose glucocorticosteroids. Do you believe that she's a good candidate for a CAR T trial? Would you refer her to a center for CAR T therapy? So the answers are no, I'd like to try steroids again. No, I'm not convinced there's a role for CAR T. Perhaps but I need more evidence. And yes, CAR T represents a good option to pursue in refractory lupus. Please use the... Well, I'm truly glad to see that you all believe that CAR T is a good option for refractory lupus and for the story of this particular patient. Please, let's talk some more if you're not convinced. So there's a lot of complexity to the process. Manufacturing takes a while. This is a very expensive process. It's logistically complicated. There's a lot of trouble with care coordination and team complexity. We need infrastructure to meet the current and future demands for inpatient, outpatient, and long-term monitoring. So we need to figure out how to meet these challenges. We need to try and figure out how to do CAR T delivery in outpatient as opposed to inpatient, which is a lot more cost-effective. Develop manufacturing, developed CAR T products that have faster turnaround. And of course, train rheumatologists and hematologists in how to best deliver CAR T therapy to people with lupus. We talked a little bit about the concept of autologous versus allogeneic. Allogeneic CAR T is donor-derived, off-the-shelf, can be given to any patient. NK CARs are engineered from donated blood and use, instead of the T cell killing power, they use the NK cell killing power. It's lower cost, they're faster to produce. Two products are being explored, NKX019 and AB101. They're both in clinical trials in the US. In China, there are a lot more options in terms of people developing CAR T products. So a little side-by-side of autologous versus allogeneic. And there are pluses and minuses to both. So autologous is single dose, allogeneic can be adapted to patient response. Manufacturing, because allogeneic products are off the shelf, it's less of a problem. It may be done in outpatient, manageable infusion reactions, less incidence of CRS and ICANS. So the intrinsic cytotoxicity is enhanced. So there are pluses and minuses, and maybe there will be a time when we'll figure out which type of CAR T is correct for each patient. And one more thought about what's coming down the pike is the bispecific T-cell engagers that are engineered monoclonal antibodies that can be given subcutaneously, so very easy to administer, use the patient's own T-cell to target and destroy B cells. Several agents have been approved in the oncology space, and several T-cell engager trials are ongoing in lupus. So the final question, what did you learn today and what made the most impact? Currently available therapy for SLE is imperfect for refractory disease. A one-time infusion of CAR T may lead to sustained drug-free remission. Assessment of treatment history and organ involvement can help identify candidates for CAR T. Unique toxicities for CAR T include CRS and ICANS, and all of the above. Well, I'm so glad, all of the above. For the most part in this session, all of the above has been the correct answer, almost always. So we received some questions from our virtual audience. Please send questions through your QR codes, and we'll do our best to answer as many as we can in the last several minutes.
So one of the questions was, would you consider a patient with more renal dysfunction than has currently been allowed in the study? One of the things that we have been sort of challenged by is the inclusion criteria require that the patient be refractory to treatment, but on the other hand, they have to be healthy enough to go through the whole procedure. And one of the things that they don't want is to have a patient with really significantly destroyed kidneys. So one change that's occurring is we're seeing a shift from a GFR of 45 down to as low as 30 to be allowed in studies. So the answer is yes, there is movement toward allowing patients in who have more damage, but you can appreciate the point that in order to show greater impact, you at least need to have a certain amount of renal preserve to start with. Do you want to add anything to that?
So I think that we understand more and more that early intervention in lupus and early treatment prevents long-term damage. We are now advocating for triple therapy for lupus nephritis off the bat. We are advocating for the introduction of biologics early in the course of renal and non-renal disease. So I do believe that there will be hopefully soon a role for introducing the opportunity of cell therapy much earlier in the course of LN. One could argue that the first episode of the LN would be the best time to use CAR T therapy, because if we cure kidney disease, then we preserve renal function.
So that goes into another question, which is, will we see a point in the future where we will use this in patients with mild to moderate disease early on? Do you want to try to address
So I think that that's a complicated question. I think that as we develop biomarkers of progression, as we develop biomarkers of the potential for severe disease, it is very likely that we will be more comfortable using much more aggressive regimens early. For right now, it seems that that question is premature, but I'm quite certain we should be able to answer it more precisely in a couple of years.
Here's one. So there's a question about the reliability of the first step in the autologous cell programs where we're doing leukapheresis. Is it always the case that the patient will have manufacturing success? And the answer is no. In the cancer experience, there are occasional patients where their cells just may not be manufacturable, and so what's called manufacturing failure has occurred. This also has occurred in the lupus population, but interestingly, that when repeated, patients may have a successful manufacturing. There are a variety of factors that go into why manufacturing might fail, including cell properties of the T cells themselves, the state of treatment of the patient, and so on. But so that it can occur, but it's not frequent. A question about pediatric use. So I don't know the data myself, but I know that where in Seattle, where I'm at, the Children's Hospital has a CAR T manufacturing capability, just the center itself, and they're just beginning their lupus trials with their own manufacturing facility. So at least I know it's underway. I don't know data. Do you know anything?
So the FDA has clearly discussed the possibility of having pediatric patients included in these cell therapy trials, and that's based in part on the fact that a lot of the patients that are currently treated are patients with pediatric onset lupus. So the first step will be allowing adolescents, and then hopefully extending that to pre-teenagers.
I guess that's okay. We're now at time. Thank you very much for attending this session this morning. I hope it was helpful for you.